Thank you.
Thank you very much, Evelien. I guess I first have to speak with Wendy with sharing all these pictures, right? It's a pleasure to join you and to see you in a way here all together, even though we all would have been much more happy to see each other live. So let's hope that this can be done again next year. This is a good replacement, a good alternative, but the live meeting would certainly be better. And I look forward, like you all do, to see each other again, because this has been such a wonderful group of friends for so many years already, all shared for one purpose: to start and implement colorectal cancer screening worldwide, increase uptake rates, and further improve and introduce new techniques. Evelien asked me, and Michael asked me, whether I could tell a little bit about this management of COVID. I feel a bit awkward about it because it's actually talking about another disease and about other management, but in a way it also touches upon colorectal cancer screening and management. And I think the things that we learned, I guess most of you have in one way or another, each in your own environment, been involved in management also of COVID patients. I also guess that your background in colorectal cancer screening and implementation and management of programs has helped in doing so. For me, it certainly did. And with that background, I'm happy to share a little bit. So I was asked to say a little bit about the forefront of management of COVID-19, in this particular case, with a focus on the Netherlands. Can I have the next slide? Because again, yeah, thank you very much. Like in most places, what happened in the Netherlands is that COVID, the SARS-CoV-19 virus, came very rapidly, largely came without us being aware of it. We first saw a first patient coming into our hospitals by the end of February, then a number of patients in the first 2 weeks of March. And then things went very, very rapid, like you've seen in different places, most likely also in your own environment. With us, the main outbreak was in the southeast of the Netherlands, here marked by this red square. This is where most of the patients came and were first presenting themselves to a hospital. Can I have the next? And this led to pictures that you have seen in many different places, with a very rapid surge of patients, in particular patients at ICUs, many also at outpatient clinics and emergency units, and in particular hospitals in the south of east of the Netherlands. After having seen the first patients coming in for 1 or 2 weeks, very rapidly, basically in a number of days, numbers of patients that came in were completely overwhelming those hospitals, and they needed help. They had they did not have the ability to do that on themselves, nor with their direct regional colleagues. And it was clear that help was needed. And that was the moment that I was approached by the Minister of Health in my role that I already had before as chair of the Dutch Emergency Network. This is a network which covers 11 different regions. And in those regions, it connects all the hospitals, the primary care practices, the ambulance services, helicopter services, and everything else that is involved in emergency care. And this network was then being used, if I can have the next slide, to start a control center for patient coordination of COVID patients. We based the center temporarily at the teaching center of Erasmus Medical Center in Rotterdam, simply for reasons of available space, because all the medical school programs had been stopped. And basically overnight, with help of the Dutch Army, we set up a coordination center. The main room, the coordination room, or what the Army called the battle room, is seen on the middle picture on the bottom, where different hospitals could call in and report in patients that needed to be transferred to elsewhere, whether they were ICU or clinical ward patients or anything else. They were then being taken care of here in the control room, and a connection was made with any other hospital anywhere else in the country, and at some point also to German hospitals for outplacement, coordination of data transfer, of transport, either by helicopter, mobile ICU, or by regular ambulance. And if you look at the upper middle picture, you see a helicopter for transport of COVID patients. Just imagine that you're there taking care of a patient on a ventilator, on a monitor, with all the infusion pumps at 50 centimeters distance for a flight, for instance, from a Dutch hospital to a German hospital. If I can have the next slide. It then, in the connection, led to daily calls with all my colleagues in the different regions and daily updates on their, in this case, for instance, ICU occupancy rate. So to the left, you see the different emergency care regions. Evelien is in the northwest with Amsterdam. Rotterdam here is the southwest. These are the two largest regions of the Netherlands in terms of population. And then we gave the feedback information for every region in terms of occupancy rate of their ICUs. In this case, to the most right column, occupancy rates ranging somewhere between 150 and 184% of normal. At the peak, we were everywhere above 225% of normal. If I can have the next. So to manage this, we really needed real-time data on available capacity, waiting times, pressure, and numbers of patients at emergency units, available capacity at the ICU, etc. And in that respect, the experience that we had here with the colorectal cancer screening became very, very helpful, because during the crisis, we made a web-based or internet-connected system connecting all the electronic health records of all the 90 hospitals in our country, which provided us with panels like this, giving insight for all the hospitals in one region and zooming in to the left on one particular hospital and seeing at the coordination center, actually having a watch at their particular ICU or emergency unit on numbers of patients, waiting times, their clinical characteristics, etc. And this helped us to allocate patients from one hospital most efficiently to another one. Next one. Half of March, so the first patients came in here at time 0, which was end of February. I mentioned that first 2 weeks of March, we saw a slow rise and then it accelerated. And half of March, March 15, the country went in almost complete lockdown. And despite the complete lockdown, the graph depicts the number of COVID patients on our ICUs. And you see what happened is, despite the lockdown, so despite a real decrease in viral transmissions, it took another 3 weeks before we reached the peak. And as we know now, this is exactly the time from first incubation period, then preclinical symptoms, and then half of the average ICU admission time. And you also see at the lower half that after reaching the peak, or overall, it took 12 weeks from lockdown to the baseline level again. This is the oil tanker that you're trying to steer. If I can have the next one. So we were then able to set up a national dashboard with confirmed cases per 100,000 inhabitants, number of infected people, the reproduction number of the disease, hospital admissions per day, intensive care admissions per day, and also, for instance, to the lower right, sewage water examination data on sewage water, also providing input on viral transmission in a population. Next one. This was all done well, but it also came at a price. And here the colorectal cancer screening was one of the programs that really had a damage, and it was temporarily completely stopped. What this graph shows is in blue, for 2019, the weekly number of hospital referrals from primary care to a hospital. And you see that for the average week, this came to approximately 125,000 cases newly referred to a hospital every week. The dip in the blue line is because there was a particular week with a holiday in it. Then in brown, you see the same results for 2020. And you see that early in the year, the numbers were higher, then came back to the average level of the year before. And then suddenly, at the same time as the lockdown, very rapidly dropped all across the country. So we went down in referrals from approximately 125,000 to, at the lowest, 25,000. And screening programs like colorectal cancer screening were completely stopped. This increased again and came back later. The cancer screening was also again started. But what we are seeing now, no surprise, is that on average, cancer patients are presenting at a later stage. So we are really seeing the damage of this graph. Next slide. Here again, in brown or orange, you see this peak in COVID patients, and in blue, the number of non-COVID patients, on average normal at the blue line, 925 patients every day in our country. And you see that at the beginning of the COVID crisis, there was a sudden drop, and it took a very long time, even up until today, for these numbers to increase again. Next one. Now we are unfortunately at a new stage. You see again the graph in dark red for ICU admissions and in lighter red for clinical ward admissions. And then we decreased June, July, August. But since beginning of September, we see a rapid surge again, first in newer numbers of infections, followed by hospital admissions. This was 2 days ago, and I can tell you that now already the total numbers have passed 1,100, and we are expecting and preparing for them to surge again over 2,000 in the coming 10 days. Next one. So that meant that this national coordination has started again, is preventing me from being bored, unfortunately. Giving again the same information to all the regions per day. This is for what regions need to admit in the coming 24 hours, left panel, then what they need to admit in 48 hours, and then what they are expected to admit in the coming 7 days. This is the mirror information that we provide to the region, and they then have to accommodate that. Next one. So overall, what I've shown is based on experience that we had nationwide, and Evelien already referred to it, how we could connect all the hospitals, also with ICT systems, giving us correct information on available capacity that allowed us to optimally spread COVID patients. But the price we paid was that, at least at that time, colorectal cancer and other programs were completely stopped. And we see the damage of that at the moment. So one thing that we really want to prevent during this second wave is to stop again cancer screening programs. We definitely should not do that again. Thank you.
Thanks very much, Ernst, for that beautiful talk. We have a few questions from the Q&A. When we have time for maybe one or two, and I'll ask the first, which is from Henk van Wert. The comment is, last Saturday, a national newspaper presented some criticism from Germany, which was basically that the Netherlands considered COVID as a hospital problem, when in fact it was a public health problem. The Dutch called in the army when the ICUs got overcrowded, and Germans called in the army for contact tracing. What's your opinion on this criticism? And should it influence the handling of the second wave?
Yeah, thank you, John. This is a rightful comment. I've always stressed, and I continue to stress, this is not a hospital problem. It has nothing to do, even though it sounds, it has nothing to do with hospitals being busy or overcrowded. This all has to do with, are we able to provide healthcare and support to the population, to any citizen anywhere at any time when he or she needs it. Now, what we see with the COVID crisis is that at some point, hospitals were overcrowded and we had to decline patients who came in for a particular non-COVID related, non-emergent issue. Now, in terms of the comparison with Germany, you see that different countries call in different groups for support where they are needed. If you compare the Netherlands with Germany and the healthcare system, be aware and take in mind that Germany has 5 times the number of hospital beds that the Netherlands has. This is a different system, so they have 5 times the number of ICU beds, 5 times the number of clinical beds, etc. So it's for good reasons that they do not need the army there. We did not need the army in the hospitals, but they were very helpful in setting up in 24 hours this national coordination center. We did it ourselves as National Emergency Network, but their experience in doing this was very helpful.
Terrific, thank you, Ernst. One last question before we move on from Iris Serious, and I'm sorry if I'm not pronouncing names correctly. The question is, do you see possibilities of moving doctors instead of patients during crisis time to areas where capacity is lower?
Sure, I do. But then the question remains the same. How do you provide care to any patients with any particular condition? So we can, for instance, transfer, take ICU doctors or pulmonologists or internal medicine people. But once we move them from one place to another, again, they are not able to provide care at their own hospital. It wouldn't change the situation.
Terrific. Thank you, Ernst, for such a lovely talk and for providing such leadership in this challenging time.